Thank you, Dr. Aditya Kapoor, and my dear friend, Dr. Girimat, and thanks to Dr. Siddharth Shah, Dr. Shashank from HSI, and the and also to Shirish and the Manjula for giving us this opportunity from the micro labs to discuss about an important topic. So I'll be speaking in favor of fixed dose combination in hypertension management. So we have learned now that over the last few years, the prevalence of hypertension is globally increasing, and in our countries also we have almost 30% of the adult population, they have hypertension. But unfortunately, only 10% of the rural and 20% of the urban population have controlled blood pressure to the goal. Now, why the blood pressure is so poorly controlled, even if detected and treated? There are two important reasons. One is that probably at physician level, and secondly, as patient level. The physician level, what we found, still a lot of physicians, they continue to prescribe monotherapy in spite of the good knowledge from guideline that we need more than one drug. Secondly, they have a therapeutic inertia among the physicians that they do not escalate the treatment and do not follow the guidelines strictly. We have also learned that most of the hypertension patients in previous panel discussion that the comorbidities are very high with them and they need many more pills. And at the same time, for the control of blood pressure, they need multiple pills. And we know patients always, they fear about the pill burden, and that leads to the decreased adherence to antihypertensive treatment. And that is a big problem in real clinical practice, which leads to uncontrolled hypertension. We have a recent data coming from 15 countries, 28 studies, showing that approximately 45% of hypertensive population are non-adherent. And those who are uncontrolled hypertensive, it is almost 84% of them are not adherent to the drug. We know that the blood pressure lowering is designed to be difficult because it is maintained by multiple pressure system like sympathetic system, ROS system, and sodium handling. If we inhibit one system, the other systems gets activated. So pathophysiology of hypertension is heterogeneous, and so no single drug mechanism is going to be sufficient to control the blood pressure, as we have learned now. For example, if you use only vasodilator or diuretic, you're going to stimulate the ROS system. And that's the reason why ROS blockade has become a foundation of treatment of modern management of hypertension. We have also evidence from more than 2 decades now, various clinical trials of hypertension in various clinical settings have shown us that you need more than 2 drugs always, and maybe 3 or 4 drugs sometime to control the blood pressure. This is with the goal of blood pressure of 140/90 at that time. And now with the new guidelines, both of them, ESC and ACC, suggested keep the goal of less than 130. So it becomes much more difficult now to reach this goal with the availability. So we need to have to give more than 2 or 3 drugs to control the blood pressure. We have a strong evidence to say that if you're using monotherapy, like telmisartan 40 milligram, and if you want to double it to 80 versus adding another group of drug from different pathophysiological mechanism like amlodipine, the efficacy is 5 times more. So this is again a very important information. Compliance usually decreases as the pill burden increases. There's a study done almost 20 years ago showing at that time that if you increase the pill burden, the compliance is going to go down. And you can see here, if you use 2 times, 3 times drugs, and so the compliance reduces significantly, and that leads to uncontrolled blood pressure. We have also now data from the single pill combination versus the same drugs given as a free combination, same doses, same drugs. Although it's not a randomized clinical trials, but they are the studies from the patients, those on never antihypertensive drugs, patients those already on antihypertensive drug. And if you look into the compliance issue, you can see the significantly 13-fold increase improves if you give it to start with a combination treatment, because patients, they tend to forget the drug if they are on 3 or 4 drugs of antihypertensive management. We have another evidence which has published almost a decade ago that if you start initially with combination treatment versus the monotherapy and then having a sequential adding of a drug later on, which is generally added with physician inertia, then you are not going to improve the control the blood pressure, which ultimately leads to increased cardiovascular events like coronary artery disease and stroke. So in a nutshell, what we can say that if you use combination treatment with fixed dose combination treatment of antihypertensive drugs, we have increased efficacy, better control, maybe earlier or prompt control of the blood pressure, because we are using two different group of medicines. They have a complementary mechanism of action. They have less side effects because we have to use initially with a smaller dose of two drugs. Smaller dose of each drug will generally have less side effect. But if you increase the dose also, then also we have learned now, for example, if you're using a low amlodipine, the pedal edema is there. If you add ROS blockers, the pedal edema side effect of the drug is counteracted by the ROS blockers because their action on the afferent arterioles. And an important thing finally is the adherence and compliance improves. It becomes more cost effective, at least in us and some of the countries where they become generic drugs have been used, because the packaging is important at that time. And if you control blood pressure effectively, as we have seen in our studies, which we have just discussed, you reduce the cardiovascular events. There is a downside of the FDC also, but that downside can be managed by modifying the management strategy. Like, for example, you can have a side effect of one component of a drug like ACE inhibitor, cough. Now we have FDC easily available with ARBs, so that can be taken care of. You have a drug flexibility is a problem always. Multiple doses, FDCs are also available to us now, or we can use even score tablets to manage that. So this is a way we can, some of the challenging issues of fixed drug combination can be overtaken by the modification of these strategies. Some of the studies using the FDC versus free equivalent combination meta-analysis which have been done, although no randomized clinical trial is available at the moment to discuss about that. Few of them are going on. Light ACD, quartet, US studies are going on at the moment. I think we have to wait for one more year to give the final answer for that. But definitely FDC group have shown a 15% increase in the compliance, and the risk ratio goes increased by almost 1.84. Looking at the blood pressure lowering efficacy, we have seen that 30% better control of blood pressure in the same meta-analysis of 1600 patients, which was available to us. Looking at the adverse effect, surprisingly also, which I've told you already, probably one of the factors, that's why the side effect is also less. So the sequential management of hypertension, the other drug when it is added, by the time patient has already have side effects, so it does not help us. To begin with, if you start fixed dose combination, always beneficial to reduce the side effect. Now, the WHO has taken a step to improve the availability and affordability of these drugs to more than 1 billion people. So now they have endorsed the fixed drugs combination for the management of the hypertension, like they have now ACE inhibitor, calcium blocker, or ARB calcium blocker with diuretics, multiple combination available, particularly with generic drugs. So they become very cost effective and very effective to be used. So the WHO has clearly endorsed this FDC now. And now we have a guidelines which came 2018, ESC guideline, which they have said that single pill combination treatment to improve the BP control is a preferred use of two drugs combination, single pill combination. It is a simplified treatment algorithm for this. So you can see that they have suggested that you can use ROS blocker, calcium blocker, or diuretic, two combination drug to start with, three combination drug in single pill, and only when resistant, then you have to add spironolactone and beta blockers in special compelling indication. For beta blockers, for CAD or heart failure, they come on stage 1. Now we have combination available with ROS blocker, beta blocker, and calcium channel blocker available for this group of population where there is a need to add beta blocker for management of hypertension like heart failure. And this year, we saw 2020 International Society of Hypertension Guideline also published, and they have also reinforced the same thing of ESC guideline. Only there is some difference is that they have given only choice of ROS blocker with calcium channel blocker to start, and for stage 1 is divided into two groups, step 1 and step 2, where they've given to start with low doses of combination of ROS blocker and calcium channel blocker. If not controlled, increase to the double dose combination, which is easily available to us now, and then only add the diuretic as step 3, and then remaining the spironolactone beta blocker the way. So they have only suggested use free combination if SPC is not available, which is very easily available, at least in our country and maybe in various countries. We have now evidence from US FDA and Europe also, that they have lot of fixed combination drugs available for control of blood pressure. If you look at the market trend of the drugs in the country now, the fixed drug combination and monotherapy both are improving, but the fixed drug combination at the moment is showing a better growth, 11% versus 9% for the management of hypertension. So in conclusion, dear friends, I would like to say that the recent guidelines are actively encouraging to start the treatment with single pill combination treatment because it will a faster BP control, less variability in response, everybody responds, safe and well tolerated, less adverse effects, fewer pills, better adherence to treatment, which results in better outcome in reduction of cardiovascular events. Before finishing I've just got some information from Pune regarding the prescription of Dr. Jagdish Hiremath. 9 out of the 10 prescriptions of Dr. Hiremath contains fixed dose combination, and he believes strictly on guidelines. Thank you very much for listening to me.